What actually happens when you go on a ventilator for COVID-19? Most of us had never given much thought to what a ventilator does before the COVID-19 pandemic. Or maybe you'd only encountered that uncomfortable feeling of having a tube down your throat during surgery. But now these machines have proven to be a crucial piece of equipment in managing the most severe symptoms associated with coronavirus infections, which are known to cause intense coughing fits and shortness of breath. In the most severe cases, a coronavirus infection can cause pneumonia, a lung infection that leads to inflammation, lung damage, and possibly death. But in those cases, doctors can use mechanical ventilators to help patients breathe and give their body more time to fight the infection. Whether you know someone who's on a ventilator or you're just curious to know more about how these machines work, here's what you need to know about using ventilators for COVID-19 patients. What does a ventilator actually do? The first thing to know is that mechanical ventilators aren't some newfangled fancy machine. A ventilator is really a very simple device that's been in use for decades. Enid Rose Neptune, MD, pulmonologist and associate professor of medicine at Johns Hopkins University School of Medicine, tells Self. There's nothing cutting-edge, cosmic, or otherworldly about it. Ventilators help patients breathe via two very important processes, ventilation, and oxygenation. Ventilation is the process by which the lungs expand and take in air, then exhale it. A mechanical ventilator helps with this by pushing air into the lungs from an external device through a tube that is inserted into the patient's airway. While patients are intubated, they can't talk and are given sedative medication to make them more comfortable, medications that, according to recent reports, are now in short supply. Oxygenation is the process by which our lungs breathe in oxygen, which then makes its way to the bloodstream and internal organs. Oxygen is necessary for those organs to function, and a ventilator can provide more oxygen than you might get from just breathing in regular air. In fact, patients dealing with COVID-19 tend to require relatively high levels of oxygen compared to people who need to be ventilated for other reasons, Dr. Neptune says, and this is one of the many unique challenges of treating those patients. All kinds of complex oxygenation and ventilation pressure settings need to be individualized and consistently monitored for each patient who's on a ventilator. And those settings often change as time goes on, Dr. Neptune says, which makes the idea of splitting a ventilator between multiple patients very challenging to actually accomplish. There are other, non-invasive types of ventilation that don't require intubation, having a tube down your windpipe, and deliver oxygen through a mask instead. These are usually saved for less severe cases. When someone has a condition that affects the lungs, which might be something like an injury to the muscles the lungs need to draw a breath or a respiratory illness like COVID-19 related pneumonia, mechanical ventilation can help give their body the oxygen and time it needs to recover. How long do people usually stay on ventilators? Depending on the condition that needs to be treated, a patient might be on a ventilator for a few hours or days. But there are reports that people with COVID-19 who are put on ventilators stay on them for days or weeks, much longer than those who require ventilation for other reasons, which further reduces the supply of ventilators we have available. In one study of 18 patients in the Seattle area, the average intubation time was 10 days, for instance. And previous research indicates that prolonged intubation times like these are very much the minority of cases outside of the coronavirus world. But Dr. Neptune says it's hard to know exactly how long coronavirus patients need that kind of care because our understanding of the infection is still evolving. That may translate to an extended time that someone with COVID-19 spends on a ventilator even if they may not necessarily need it. For instance, we are probably starting people on more advanced support earlier in the evolution of the disease with the concern that if we wait too long they may not get as much benefit as if we had provided it earlier, Dr. Neptune says. Under other circumstances, patients might start with less invasive forms of respiratory care, like a nasal cannula, which supplies oxygen through the nostrils. And Dr. Neptune says that many coronavirus patients still do start with these less invasive options, but may be moved to a ventilator more quickly than under other circumstances. In fact, faced with the discouraging survival rate statistics associated with those who are placed on ventilators, some doctors have begun moving away from using ventilators and started saving them for only the most severe cases. Unfortunately, the limited research we have suggests that the majority of those who end up on a ventilator with the new coronavirus don't ultimately make it off. For instance, in that study of 18 patients who required mechanical ventilation in the Seattle area, 9 of them survived but only 6 had been extubated by the end of the study. And in a more recent study, published in JAMA, looking at 7,500 hospitalized patients over the month of March in a hospital in New York City, researchers found that 1,151 of those patients required mechanical ventilation. At the end of the study period, about 25% of them had died and only 3% had been discharged. Most, more than 72%, remained on a ventilator. Mechanical ventilators can come with some side effects too. Aside from the obvious not being able to get up or talk for extended periods of time, being on the machine can increase your risk for lung infections because the tube that allows patients to breathe can also introduce bacteria into the lungs, Cleveland Clinic explains. The risk for this kind of complication increases the longer someone is on a ventilator. On the other side, it may be difficult to know when someone is really ready to come off the machine. The way most ICU doctors think about ventilation is that you don't want to remove the ventilator until the initial reason that you place people on mechanical ventilation has resolved or been addressed, Dr. Neptune says. But our endpoints for resolution of this process are not well established. Without obvious or fully agreed upon health markers that suggest a patient is okay without mechanical ventilation, doctors may be leaving people on the machines for longer periods of time out of an abundance of caution. All of these factors make it hard to know exactly what is and isn't normal timing for someone who's on a ventilator due to COVID-19. What happens when it's time to come off the ventilator? Under normal, non-coronavirus circumstances, we have very standard metrics that guide doctors in deciding when to take someone off a ventilator, one major factor being that the original reason a patient was put on a ventilator has resolved. But as we mentioned, those standards don't totally exist yet for COVID-19 patients. And early reports suggest that coronavirus patients who are taken off a ventilator still have a significant amount of healing to do at home. Still, when a patient's situation sufficiently improves, it may be time to begin the delicate ventilator weaning process to remove the tube extubation and get the patient breathing on their own again. This isn't something that happens suddenly, instead it's a gradual process in which the patient has to pass little trials and tests to see that their lungs have recovered enough to keep up their blood oxygen level with a temporary reduction in or without support from the ventilator. However, it's important to remember that while going on a ventilator may be a sign that you have more severe COVID-19 symptoms, it is not a death sentence. I don't want the public to assume that the need for mechanical ventilation means that someone is ultimately not going to survive, Dr. Neptune says. That is not the role of mechanical ventilation in this epidemic. On the contrary, if someone has symptoms severe enough to require ventilation, that's the best place for them to be. Although patients who require ventilators may be more likely to die in the long run, they are also usually the patients who have the most severe disease course or underlying conditions, which already make their chances for survival lower. But with mechanical ventilation, those patients get a little more time to see if their body can fight the infection. It's not a treatment in itself, but we see mechanical ventilation as providing a much longer window for the lungs to heal and for the patient's immune system to deal with the virus. It's a good thing that we're able to do that, Dr. Neptune says. It's merely a way of extending the time that we can provide a person to heal themselves.